Welcome to today's webinar. My name is Jose Francisco, Project Manager at the IAS-USA. Today's webinar will go over trends in weight gain among people living with HIV who are on antiretroviral therapy, and will provide a summary on recent studies of weight gain in ART-naive and ART-experienced patients. We would like to introduce today's speaker, Dr. John R. Koethe from the Vanderbilt University Medical Center. Welcome, Dr. Koethe.
Thank you. Thank you so much for having me. So before we start, we'll go through, and thank you everyone for joining as well. I can see some chats from a few people, including a few I recognize in the list as well. So I'm really delighted to have the opportunity, and thank you also to IAS for the opportunity to present this. So before we start, we're going to go through some introductory slides and a quick pretest. I just want to say that the IAS-USA has designated this live activity for a maximum of 1.25 CME credits for those who would like to claim them. Additionally, the webinar is also approved for 1.25 hours of nursing, pharmacotherapy, and pharmacy credits as well. Our activity today is possible through the generous support from the following contributors. Those include Gilead Sciences, Merck & Company, and Viv Healthcare, with additional support provided by Janssen Therapeutics. As we go through the webinar, we're going to have a poll question that'll appear in a separate window. It's a multiple choice question. Select just one answer, and please select it on the poll, not in the chat box, and then we'll display the responses after that. To ask any questions, you can type those into the chat box, and we'll go through the slides and presentation first, and then we should have about 15 minutes at the end for questions. Thank you as well to everyone who pre-submitted questions. So I've reviewed all of those as well. And if you want to repost them, or if the moderators put them up, we can address those as well. So first off, if you could just indicate which region you're viewing this webinar from. All right, so it looked like Northeast took the cake there. Having trouble removing my poll. Perfect, okay. Poll number 2, if you could rate your level of experience in the medical management of HIV infection, everywhere from 1 to 5. Good number of 3, 4, expert. Okay. Looks like we've got a good range of answers, with many people in the 3 to 4 range. Very good. All right, now I think we can move on to our learning objectives. So the goal today is really to identify the recent trends and go over a lot of the recent studies on weight gain among persons living with HIV after starting antiretroviral therapy or after switching to new regimens. And in addition, we're going to try and focus on some of the new data from CROI and information presented at IAS earlier this month. We'll describe why weight gain matters, and in particular go over cardiovascular and metabolic aspects. And then we'll summarize some of the recent studies of weight gain in ART and ART-experienced individuals. We'll start off, though, with a pretest question. So you are seeing in clinic a 49-year-old obese woman, so that would be someone with a body mass index above 30, in this case 33. She's Caucasian with a new HIV diagnosis. She has a CD4 count of 181 cells per microliter and a HIV RNA level of 93,000 copies per milliliter. She started on dolutegravir, abacavir, and lamivudine, and after 12 months, her weight has increased from 250 pounds to 280 pounds. So she falls in that group of individuals with more than a 10% early weight gain. So which factors have been associated with her weight gain after ART initiation in prior studies? Okay, very good. So the correct answer is actually 4. So about a quarter of the folks got that. Answer number 1 was very similar, though with the pretreatment obesity as opposed to female sex. So that's something we'll cover here, looking at how sort of individual factors before starting ART can influence these outcomes. Okay, so let's start off. So I think that, generally before we even get to the question of weight gain and antiretroviral therapy, I think it's important to sort of put this question into context and recognize that it's actually a relatively new area of research and interest in HIV clinical care. So really, if we go all the way back to the pre-ART era, 1981, for over a decade, we were primarily focused on the prevention of weight loss and also wasting disease among individuals with HIV, particularly before the introduction of effective combination antiretroviral therapy, and even after the introduction with individuals developing resistance and no longer having effective therapy options. When early combination ART, and particularly first-generation protease inhibitors became available, we saw improvements in survival, but rather than weight gain, we oftentimes did continue to see some early weight loss, and then when we did see gain, we were very concerned about where that gain was occurring. And there was a tremendous interest in both the peripheral lipoatrophy, or loss of limb fat, and redistribution of that fat to the dorsal cervical area and also to the central area, much of that actually representing visceral fat, or fat that's below the rectus sheath and around the internal organs. And that was a clinical concern, and in fact, at the height of some of the lipoatrophy and lipohypertrophy interest, survey studies were showing up to 50% of individuals who had been on ART for a prolonged period of time showed evidence of either lipoatrophy, lipohypertrophy, or a mixed picture. With the introduction of less toxic antiretroviral agents, including phasing out some of the thymidine analogs and older protease inhibitors, we're now entering a time where we don't see as much redistributive weight gain, but we are seeing weight gain in general among individuals starting ART. And in particular, we're seeing rising rates of both overweight and obesity and all the metabolic complications that can come with those conditions, now in part compounded by some of the effects of HIV virus itself and antiretroviral therapy agents. So from a 10,000-foot view, though, before we get too much further into this, I first want to point out that the weight of individuals starting antiretroviral therapy has increased over the past few decades. And so this is data from 1998 to 2010, looking at body mass index at the start of antiretroviral therapy in NA Accord, which is a multi-site collaboration of over 25 cohorts covering 200 plus clinical sites across the United States and Canada. And what I want you to take from this is that the body mass index of people starting antiretroviral therapy over a 12-year period increased from 23.8 to 24.8, which was exactly the same as the increase in the body mass index of age, race, and sex match controls from the NHANES cohort, only to make the point that essentially persons with HIV are not living within a vacuum, and to the extent that the United States, individuals in the United States are generally getting larger and have been over the past 3 decades and only now maybe beginning to plateau, we're seeing the same environmental or obesogenic effects occurring in individuals with HIV. That said, though, the weight gain that's happening on antiretroviral therapy is real, and it is also leading to shifts in the BMI categories of our patient population. So what we've seen really in that same period from 1998 to 2010 was that after 3 years of antiretroviral therapy, a full quarter of those individuals who are normal BMI, or body mass index of less than 25, had become overweight, or a body mass index of 25 to 30, and approximately a fifth of those who started antiretroviral therapy overweight had gone on to become obese. So when we try to put this into context of the environment that individuals are living in, I think it's important, first off, to just review where the various regions are in terms of the prevalence of obesity since 1975 up until the midpoint of the past decade. And as you can see, the obesity prevalence in North America and Europe increased from around 10% of the population in 1975 to approximately 30% of the population in 2015. Now, worldwide, that rise has been less, but you're seeing also in Africa and Asia, two areas that previously had very, very low rates of obesity. Things are beginning to creep up there. And why is that important? Well, many of the individuals with HIV, in terms of where the highest prevalence is, co-locate with those areas that have the highest prevalence of obesity. So if we consider the environment that our patients are living in, for many of them it's what we would oftentimes refer to as an obesogenic environment. And if you look at the counties that have the highest HIV prevalence, you also see those counties, particularly here in the southeast, as having the highest obesity prevalence. And interestingly, you can overlay a lot of different maps and see the same effect. If you overlay the areas with the highest stroke risk, it's going to be in this area. Highest cardiovascular disease risk, this area. Highest COPD risk, this area. Important to note, if you overlay a map of average income, you'll also see that many of the areas with the highest HIV prevalence also overlap with the areas of poverty. So these individuals oftentimes are living in environments where they may not have access to all of the nutritious foods and other resources that are available elsewhere. So the rise of overweight and obesity in the HIV population really reflects both general, or what we sometimes call secular trends in the environment, and then also HIV-specific factors. So a few that I want to highlight are the obesogenic environment I mentioned, which includes changing dietary and lifestyle patterns, often towards more high-calorie, nutrient-dense foods, processed foods, and also higher intake of saturated fat, meat products, etc. And then also differences in lifestyle patterns, people spending less time walking, more time sitting, and oftentimes less exercise. And then we're also seeing, as I mentioned, an overlap of the HIV and obesity epidemics in key populations. So in the Southeast, that includes African Americans and Hispanics. We're also seeing HIV prevalence high among individuals with lower socioeconomic status, and then, as I mentioned, specific geographies. There's also HIV-specific factors that are coming into play. We are diagnosing people earlier, but we're also starting them on antiretroviral therapy earlier, oftentimes at a higher BMI than they would have had if they had undergone weight loss that sometimes accompanies untreated disease. And when we link them to care and treatment, it's also now often accompanied by access to other resources. That might include food assistance and benefits. That might include smoking cessation, also associated with weight gain. And finally, it might also include mental health treatment with some of the weight gain that's seen on some of the antipsychotics and also on antidepressants. And then finally, there's the potential role of ART agents that we'll get to next. But before we do, I just want to show this slide, which I think some people may have seen before, simply to make the point that in many ways the HIV aspects of weight gain are much simpler than the environmental or sort of host aspects. So when we think about weight gain in HIV, we think about the various antiretroviral agents. We think about the effects of inflammation. We think about microbial translocation, which can contribute to the accumulation of visceral fat. We think about changes in energy absorption. We think about changes in lipid trafficking and some of the ectopic fat deposition. And finally, we see differences in adipose tissue. All of those are areas that we've been exploring for many years and continue to explore, but sometimes we forget when we look at our individual patients that there's this entire environment around them. So diet might include, what are people's food preferences? Do they actually have food security? And we oftentimes think of food security as access to sufficient amounts of food or calories. But food security is also access to fresh vegetables. It's access to oftentimes more expensive, leaner items than they might otherwise be able to afford? And then lastly, is there actually access to foods regardless of their economic resources within the areas that they live in? So it's the food deserts of urban areas. In terms of activity, there's preferences for regular exercise, but there's also opportunities for physical activity. Some neighborhoods are not walkable, some neighborhoods are not safe. So we have to consider, where does the person fall in that area? In terms of the host, we have to think about race and ethnicity, and we'll see some of the effects that can have later. Sex, genetics, which we'll get into. Other comorbidities, for example, things that might limit their mobility, osteoarthritis of the knees being one common example in individuals who are heavier or have other medical issues. And then other medications they might be taking. Some of their habits, including smoking, alcohol, or illicit drug use. Mental health factors such as depression, stress, which can sometimes limit individuals' interest or ability to participate in exercise. And then finally, the environment that they live in. What is sort of the sociocultural knowledge, the economic resources? And then just as important is, what are the attitudes and beliefs regarding diet? What do people think a healthy diet is? What do they think the role of exercise should be? And finally, what's their conception of health? You know, in many areas, what we might consider thin by some individuals would be considered overweight by others, and vice versa. So this then brings up the question, before we also get onto the individual drugs, is what's return to health and what is potentially detrimental weight gain? So I think that was really an open question because we did not have good data comparing folks with HIV starting antiretroviral therapy to well-matched controls. So in the NA core data I showed, really that looked at individuals in NA core starting antiretroviral therapy and compared with NHANES, which is a sort of survey of the U.S. population. And that data was relatively fuzzy. There was no adjustment for geographic area, for example, other kind of sort of background health habits. So we got a little closer to this question, though, with a really fantastic presentation by Michael Silverberg from Kaiser at IAS, or sorry, AIDS 2020 earlier this month. And he actually looked at weight over time among individuals with HIV who are starting ART matched to individuals with the same age, sex, and race ethnicity in the same year at the same clinics within the Kaiser system. So these were all people from the same geographic areas, oftentimes involved in the same employer-sponsored health coverage. And what he found basically was that there was not a plateau that really occurred after initial weight gain, but instead the slope of weight gain over a 12-year period for somebody starting ART remained 3 times greater than the slope of weight gain for a individual without HIV from the same clinic, indicating that there's not sort of an initial burst of return to health and then everything sort of levels out. But really what these data are suggesting is that after people start on ART, there is a persistent increase in weight that goes on over time. So the obvious question then that comes up, is this all being driven by just one group? So for example, are the slopes that we're seeing among individuals with HIV all being driven by those who had really severe weight loss and who might take a decade to sort of regain their normal weight? And thus we would not expect to see something similar in those who are overweight or obese. But that's actually not true. So in this particular study, as you can see from these slopes, the slope of the green line is consistently steeper than the slope of the purple line, which represents the HIV-negative controls. And for the obese, there's actually some weight loss that occurred over 12 years in the HIV-negative while it continued to climb. So this is something that's occurring in all different BMI categories. And it is something that does seem to not be sort of a quick burst with a return to health and then a normalization, but rather a persistent issue. So now let's turn to weight gain in ART-naive persons, and we'll review some of the recent data there before we move on to switch studies. So the first, I think, study we should look at, again, comes from NA Accord, and this was presented at CROI in 2019, and then was published in JIAS in 2020. And this looks at 22,900 patients who were starting antiretroviral therapy between 2007 and 2016 in the U.S. and Canada. And again, this covers over 200 clinical sites in those 2 countries. And as you can see here, for all of the individuals, there's a real burst in terms of weight that occurs in the first 1 year of ART, and then a relatively rapid plateau to a new slope. That doesn't differ tremendously between arms. But as you can see, at 5 years of antiretroviral therapy, those who started on NNRTIs gained on average 3.7 kilograms, while those who started on PIs gained 5.5 kilograms, and those who started on integrase inhibitor-based therapy gained 5.9 kilograms. So to the extent that this study was done based on some early switch data that I'll show later suggesting weight gain on Triamec, or dolutegravir, abacavir, I want to go ahead and show you, though, the way that the integrase inhibitors broke out in this study. So this was the 4,100 individuals who started integrase inhibitors. You can see there was a marked difference. Now, this only goes out to 2 years because that was the amount of follow-up time that was available for a large number of patients on dolutegravir. But you can see there's a very sharp difference between individuals on elvitegravir who gained 4.1 kilograms at 2 years, as opposed to those who were on dolutegravir at 2 years, who gained 7.2 kilograms. And just to go back to the prior slide, I want you to take a look here at what we're seeing for protease inhibitors at 2 years. So while overall the integrase inhibitor and PI-based curves were similar at 2 years with a 4.9 kilogram weight gain, really, when you spread that out to determine what went in to make that average, you can see really that the dolutegravir was about 50% greater than the primarily boosted protease inhibitors at the two-year period. Now, we mentioned in the initial question, the patient in the original question was somebody who had gained 10% greater body weight at 12 months of therapy. So we generally take a 12-month weight increase to be what we consider a severe or excessive weight increase, and that's primarily based on studies from the general population showing that once you get above about a 10% gain, you get some relatively pronounced alterations in metabolic function, and particularly increased insulin resistance and increased potential for progression to diabetes. So what are the risk factors for a greater than 10% weight gain that was occurring in NA Accord? And I should point out also that this 10% weight gain is not an entirely rare event. In fact, you'll see in studies coming up, this occurs in about 10 to 20% of individuals starting antiretroviral therapy, generally by about 2 years. And as an example, in ACTG, A5257, it was seen in 21% of individuals starting raltegravir. So approximately, 1 in 10, 1 in 5 individuals starting ART are going to have this really metabolically detrimental weight gain. And what are the factors that seem to go along with it? And now the weight at 2 years is shown in the open circles. So definitely a higher odds of a greater than 10% weight gain with integrase inhibitors, higher odds with protease inhibitors, not quite the same as the integrase inhibitors. Women seem to be much more at risk of a abrupt 10% weight gain as compared to men. However, race does not really seem to be as much of a factor. And we will later on, though, look at some of the switch data where race does seem to be a factor, but we're not seeing as much of that, at least in NA Accord. Older age probably does, younger age probably does play a role, and actually being older may be slightly protective against a very rapid weight gain. And then, as we looked at before, actually lower body mass index, not pre-existing obesity at the time that you start antiretroviral therapy, is associated with greater weight gain. And then finally, one of the strongest risk factors that was mentioned in the earlier question was a very low CD4 count, which really outweighed everything else in this study. So one issue with looking at observational data like NA Accord is you have all these unknown confounders. I'm not saying you can't draw very valid conclusions from observational data, but one question that comes up was why did a certain patient get an integrase inhibitor as opposed to getting an NNRTI or a boosted protease inhibitor, and could that have somehow affected the outcome? So this is pooled data from 8 pharmaceutical randomized controlled trials in over 5,600 ART-naive individuals. And they were randomized to a variety of different regimens. And then the data on all of these different regimens was sort of pulled out from the results, pooled together, and we can see the results here. So when you take out the possibility for unknown confounding and you rely on randomized data, what you see here is you actually see that over the course of 96 weeks, there's considerably greater weight gain among those that were starting integrase inhibitors in this study. And this is a combination of people who are starting, or a composite of individuals starting bictegravir, dolutegravir, and elbitergovir. However, interestingly, unlike the NA-ACCORD data, there was an initial rise in protease inhibitor weight gain as compared to NNRTIs, which then does seem to sort of equalize here. So that was a definite unusual factor, which did bring up some question about why this was not seen in the NA-ACCORD study as well. But I do want you to now look over here where we actually break out the individual integrase inhibitors. And as was seen in NA-ACCORD, there seems to be considerably less weight gain with boosted elbitergovir as compared to bictegravir and dolutegravir. And these are not trivial numbers, and they are somewhat similar to what was seen in NA-ACCORD. So at 2 years, remember, we saw on average about a 4.9 kg weight gain. Here, we're seeing closer to a 3.5 kg weight gain. Again, at NA-ACCORD, we were seeing 7.2 kgs on dolutegravir. Here, we're seeing somewhere in the range of about 4.5 kgs. So slightly different results, but similar overall when you look at the comparisons. And then the risk factors again in this particular study for weight gain in the pooled data. Again, a CD4 count less than 200 seems to have the highest odds of weight gain. So it is those with more advanced immunosuppression. A HIV RNA greater than 100,000 was associated with greater weight gain, and that's something that's been seen in ACTG studies as well. A BMI that is normal versus overweight, again, a higher risk of weight gain, and then a BMI that is normal versus obese, again, a higher risk of weight gain. So it's really those with more advanced immunosuppression, lower initial body mass index that seem to be most at risk. Again, we see here women being at more risk. Unlike the NA-ACCORD, black race did come out in the pooled data, which was a difference there. And then the third ART agent, I think we've sort of been over this before, really bictegravir, dolutegravir versus Efavirenz. Again, even elbitergovir versus Efavirenz, we still see higher weight gain, but interestingly, we did not for atazanavir versus boosted atazanavir versus Efavirenz. Now, most of the data I've shown you so far is all US, Canada, including a number of the sites for the pooled analysis. So now let's go across the ocean and let's look at the NAMSIL study in Cameroon. So this was one that randomized ART-naive individuals to dolutegravir or Efavirenz, both with 3TC TDF. And as you can see here, again, in this population, we saw, among men, we saw a higher risk of greater than 10% weight gain of 26% at 1 year, as opposed to only 19% in the Efavirenz group, but not a statistically significant difference. But look here at this. This is really striking. We see a 44% incidence of greater than 10% weight gain at 1 year among women in this who are starting dolutegravir-based regimens with 3TC TDF versus only 34% in the Efavirenz group. Now we'll look next, going a little bit further south, down to South Africa. So we'll look at the ADVANCE study. And this was one I think that generated a lot of interest because of the arm that's shown at the top in red, the DTG FTC with TAF arm. So again, these were ART-naive individuals who were randomized to regimens of dolutegravir with TAF, dolutegravir with TDF, or Efavirenz, as we saw in NAMSIL mixed with TDF as well. And here are the weight slope, or the weight curves for both men and women who were in ADVANCE. And what I want you to see here is there's at 96 weeks, there's a considerable difference in where the male participants ended up in comparison to where the women ended up. And I think the striking difference is that in the men, you see the lowest weight gain of only 1 kg with the Efavirenz TDF FTC. You see about a 3 kilogram premium with the addition of dolutegravir, and you see about a 1 kilogram premium with the addition of TAF. But it's really in the women, which I'll remind you in NA-ACCORD and also in the pooled trial data, we're most at risk of weight gain, where you see a 3 kg weight gain among those on Efavirenz, a 2 kg premium, if you want to call it that, when we swap out the dolutegravir for the Efavirenz, and then this remarkable 5 kg difference among those who are receiving dolutegravir with TDF versus dolutegravir with TAF. So this, I think, really caught the field's attention and really brought TAF to the forefront as one of the other agents we'll look at, and I'll show you some data on that in a moment. But I think this is really pretty striking. And then more recent data was shown earlier this month, going out to week 144, and these individuals actually did continue to gain a bit of weight, and no, they did not plateau and begin to decrease as we might have hoped. So if we look here then, as I mentioned, we're going to look at TAF. So now if we go and look at the pooled clinical trial data for TAF alone, so this has been kind of pulled out, as I mentioned, from 8 different studies. We can see that there is an increase in weight among those who are receiving TAF when you hold the other agent steady, as compared with abacavir here in the middle, and then TDF sort of lagging at the bottom, and AZT, which was not really associated with weight gain, but we don't really use it very much anymore. The difference is relatively striking. So you essentially go over a course of 96 weeks when you hold the third agent steady, and basically all these individuals were on lamivudine or FTC as the last agent. You see about a 4 kg weight gain among those who were going on to TAF versus about a 2 kg weight gain among those who were going on to TDF. And then if we look at the AMBER study that was recently published, which randomized individuals to boosted darunavir, boosted with cobicistat, with TAF, that should be FTC, versus boosted darunavir with TDF and FTC, you see that the individuals who were randomized to TAF basically gained about 1 kg more than they would have otherwise. So we'll return to TAF when we talk about switch studies as well. So that covers most of the more recent data on ART-naive weight gain. So I wanted to begin to talk a little bit more about some of the weight gain after ART switch. So the first, one of the first studies that really came out on integrase inhibitors and weight came out of the southeastern U.S. at our institution. And it was a retrospective single-site study, looked at only 195 people, and it took adults who were on Efavirenz, TDF, and FTC, who'd had viral suppressions for 2 years, and were then switched to an integrase inhibitor, versus a control group who then continued on Efavirenz for an additional 2 years. And what was seen was that there was this sort of upward slope that was occurring among those going on to integrase inhibitors, shown here, as compared to those who remained on Efavirenz. But it was really strongest for, in this particular group, which was all Triamex, DTG, ABC, 3TC, where you can really see this very sort of notable slope change. So I think to a certain extent that got a number of people interested in the area. But then additional weight studies that have come out have really refined this question a bit more. So these are data that was presented by Jordan Lake at CROI in 2019, and then published in Clinical Infectious Diseases earlier this year. And this is pooled AIDS clinical trial group data. And as you can see here, there's a slight sort of a U-shape, but generally stable weight among individuals who were on, at the time, PIs versus NNRTIs, who then switched to an integrase inhibitor, which happens here at time 0. And you can then see a really upward slope weight there. And there it was women, people of black race, and then persons who are age greater than 60 who experienced the largest increases. And I'll remind you that in the ART-naive studies, it did seem to be younger individuals who were most at risk of weight gain. So here in the switch studies, it does seem to be older individuals. And when the individual INSTIs were broken out, it did appear, now there was no bictegravir in this study, but it did appear that dolutegravir was associated with the greatest pre-post difference in weight gain of 1 kg per year greater weight gain or greater slope in the years after switching as compared to the slope before the switch. That was then followed by EVG, and then lastly, raltegravir is actually relatively flat in this study. So that was then followed by some data from NACORD, which again is our multi-site cohort, which looked at weight change after switch from an NNRTI or a PI to an INSTI-based regimen. And this actually broke out the 2 separate analyses. So we can see what is the effect of going from an NNRTI and what is the effect of going from a PI. And really you can see from this unadjusted curve that there does seem to be an increase in slope among the NNRTIs. That's not present with the PIs. But really I think you want to look at the adjusted models here, where you can see that altogether for those who were on an NNRTI, they were gaining approximately 0.6 kgs per year, which is actually, let me sort of right in the middle where we expect normal weight gain among most Americans to be. But then, after they switched, they had an increase in their weight slope to 1.1 kgs per year. So an absolute increase of about 0.6 kgs per year on top of where they were before they switched. Most of this seemed to be driven by dolutegravir in this group. So as you can see, those who are on NNRTI before the switch, who then switched to dolutegravir, were gaining about 0.8 kgs per year. And that slope doubled after they switched to dolutegravir. When we look at the PI to INSTI, though, we don't really see that at all. And in fact, in some of these groups, we actually saw that they were gaining weight on the PI, and then they switched to the INSTIs, and they either had some weight loss or they had a remarkable decrease in their weight slope, the only exception to that rule being EVG, dolutegravir. So then when we actually broke it out into individual groups, we did again see, we'll start over here with age, we did again see similar findings to what was reported in ACTG. So really it was the older patients who were most at risk of weight gain after switching from an NNRTI to an INSTI. It was non-white individuals most at risk of an increase in their weight slope after switching from an NNRTI to a INSTI, and then again it was women who were most at risk of a weight slope increase. So slightly different findings from the ART naives and the ART switch, from NA-ACCORD, ACTG, and the pooled clinical trial data plus individual studies that I showed you. So what could explain this difference with the NNRTI to INSTI switch? So I think actually data that was presented earlier this year from Advance may hold some of the answer to that. So this was, I think, one of the more interesting things that I saw at CROI 2020, and this is from the Advance study. And what this is showing you is it's showing you the curves of weight change among those participants who were randomized to Efavirenz 3TC TDF based on their Efavirenz metabolizing genotype, which is the CYP2B6 enzyme. And so what you see actually, what this enzyme does is it essentially metabolizes Efavirenz, and so it has to do with how quickly you clear that drug from your body. So individuals who are slow Efavirenz metabolizers are going to have higher levels of circulating Efavirenz. And what they found was that weight gain really differed whether people were a slow metabolizer, an intermediate, or an extensive. And those individuals that were slow metabolizers actually didn't gain any weight at all. Those who were intermediate metabolizers gained maybe just a touch of weight, and really all of the weight gain that was observed in Advance for the Efavirenz arm was primarily driven by those who were extensive or fast metabolizers. And the interesting thing you can see here is that those who were extensive or fast metabolizers actually gained more weight than though it may not have been statistically significant, but very close. They gained actually potentially more weight than those who were on dolutegravir FTC TDF. So why is this important? Well, it does bring up the possibility that the sharp increase in weight gain we're seeing with the NNRTI to INSTI switch has nothing really per se, does not have as much to do with the INSTI drug as it actually has to do with coming off of the NNRTI. So that is something that I think is going to be explored a little bit further, but I wanted to show you this abstract from CROI 2019 as well, which was a single site study, really doesn't need to be replicated, but what you're seeing here is you're seeing weight gain on new INSTI-based regimens according to whether they were, again, that slow, intermediate, or fast metabolizer. And I think what you see at both week 24, but also at week 48, is everyone who gained weight on the integrase inhibitors, the same integrase inhibitor regimens, were coming off of Efavirenz as either an intermediate metabolizer or a slow metabolizer. So in the case of the switch, particularly with the NNRTIs, it may not really matter so much where you're going in terms of your INSTI as where you've been in terms of your particular NNRTI and your metabolizing genotype. So stay tuned. I think we're going to see more really trying to unpack this. And then lastly, let's talk a little bit about TAF and weight gain after ART switch. So there was really some only sort of observational data in this area, which was back from 2018. And this was a European study that was looking at individuals who switched to TAF, keeping their other aspects of their regimen the same, versus some control individuals who then continued on TDF. And as you can see here, those who were switching to TAF had a slow rise in their weight over approximately 1 year period, whereas those on TDF had a they're sort of difficult to explain hump-like shape and then came back down. But I think really the takeaway was that they were quite similar. But this was then supplemented more recently by randomized control data, which I have a little bit more faith in, which was presented by Dr. Paul Sachs. So this was study 4030, which was a switch from dolutegravir plus TAF FTC to either, or TDF FTC to abictegravir with TAF FTC. And what you can see was that those individuals who switched from dolutegravir to bictegravir and continued on TAF, meaning that they were on it prior to the switch, they gained 0.6 kgs really over the course of 48 weeks. But those individuals who were here, who had been on dolutegravir plus TDF, then switched to bictegravir plus TAF, gained 2.2 kgs. So I think it's difficult to really draw too many extrapolations, but if we did want to sort of try and unpack this a little, we could perhaps say the premium of that switch was about 1.6 kgs at 48 weeks. So lastly in this area, I want to show you one more thing, which is then the OPERA cohort, which this was also a very nice presentation from earlier this month. And I think what this gets at and what this answers is, does it matter if when you switch from TDF to TAF, what your third agent is, or what your lead agent is? And so here, what you can see in these curves, so this is weight among individuals who are stable on antiretroviral therapy, who are on a boosted PI and NNRTI or an integrase inhibitor, who then switched from TDF to TAF. And I think what the takeaway from this that I want you to see is really here, that over the course of approximately a 12-month period, everyone had the same notch or bump and then reached, again, sort of a steady equilibrium. And you can see that sort of bumped right down here, where from 0 to 9 months, everyone who had been gaining somewhere in the range of 0.4 to 0.6 kg, or 0.3 to 0.6 kgs per year, had this remarkable rapid bump up to 2.6 kg per year weight gain at the highest point, that then very rapidly leveled off. And did not differ again between the boosted PIs, the NNRTIs, or the INSTIs, and again did not differ between elvitegravir or raltegravir or dolutegravir. So what these data show me really is that there probably is some sort of acute change that in weight set points that may be occurring with TAF, not necessarily detrimental, but some acute change in weight set point, which is preserved across the different classes and is preserved across the INSTIs. And I think one key thing is you're really going to be looking at some of the body composition, the resting energy expenditure, and other metabolic data that will hopefully come out from some of these TDF to TAF switches. So now we've laid the groundwork for weight gain on antiretroviral therapy, and we've talked about those individuals who may have a very rapid weight gain. But is there anything we can really do about this? So I think a number of the questions that I received before asked about, do we switch regimens? And I think the short answer is we don't know. And it's probably most important at this stage to treat the person with the regimen that's best for their HIV. But we are going to be getting more data in the coming months and years to give us some sense as to whether or not some individuals may benefit from a regimen switch. And in particular, I think the questions that frequently come up are, do we switch off of INSTI or do we switch off of TAF? The answer, as I just said now, is no. I think we treat people with the best regimen for their HIV. But these are some intriguing data that will be explored further in upcoming randomized studies from AIDS 2020 from earlier this month. And this is data from the DRIVE SHIFT study. So this was a multi-center study to evaluate the switch from stable antiretroviral therapy to a newer NNRTI called doravirine, along with 3TC and TDF in people who are suppressed. And those were individuals who were either switched in an immediate switch group or versus a delayed switch group. And really the difference here is going to be the amount of follow-up on the new regimen. And here are the data. And so if you look at the immediate switch group and the delayed switch group, overall, basically individuals continued to gain weight after they made that switch. But they were gaining weight at what we might expect to sort of be a stable rate for members of the general population, which is about 0.7 kgs per year from week 0 to week 144. That did not seem to differ whether they were switching off of a PI versus switching off of another NNRTI, and generally those were Efavirenz, nevirapine, or rilpivirine. But we do see actually that their weight slope did seem to go down, or their absolute weight gain did seem to go down a bit when they switched off of boosted elvitegravir. And that was the primary INSTI in this study. Now, the only thing that I think gives us pause that we need to explore further is that many of these boosted abactegravirs were mixed with TAF. So are we seeing here, if this is really a true effect, are we seeing effect of switching off INSTI, or are we seeing effect of switching off TAF? And that's something that an upcoming AIDS clinical trial group study called A5391 will address. And that will be a study that will take people who are on integrase inhibitors plus TAF with a greater than 10% weight gain in the 1 to 3 years after starting therapy, and it will switch them to an NNRTI-based regimen with TDF versus an NNRTI-based regimen with TAF, and in that study, doravirine will be the NNRTI. And that will then allow us to unpack whether a switch from INSTI back to NNR, well, I shouldn't say back, a switch from INSTI to NNRTI is associated with weight change, and whether a concomitant switch from TDF to TAF is associated with weight change. And so that study hopefully will be opening in the latter part of this year, with hopefully data available by early 2023. So for now, I think the general guidance would be no, that we don't switch people for the purpose of weight gain, but there will be more information coming out soon. So just to summarize before we turn to the last section on metabolism, so I want to summarize all the factors that were associated with weight gain on ART, and also associated with a higher body mass index in people with HIV. I didn't touch on all of these, but there's some smaller studies that should be included as well. So we talked about female sex, we talked about non-white race, we talked about age, so you lower age for ART naive with weight gain, a higher age for ART weight gain with a switch, higher weight after a switch, psychiatric comorbidities, in particular treatment of psychiatric comorbidities, hypogonadism, which I did not touch on, and then interesting data from the TRIO study on a lower AST. Among the HIV and antiretroviral therapy, the INSTIs, the boosted PIs, the TAF, certainly do look like they may have an effect. Most powerful, though, among all of these is a CD4 count of less than 100, also a CD4 count to a lesser extent less than 200, an HIV RNA of greater than 1,000, and then we touched on the potential role of the CYP2B6 in efavirenz metabolizing, particularly in those who switch from, potentially having a role in those who switch from efavirenz to an INSTI. Resistant alleles, which some interesting data at Koethe suggested could be associated with weight gain on integrase inhibitors. And then finally, lifestyle. BMI at treatment start, those who are thinner gain more. IV drug use, probably protective against weight gain. Not saying that's a really good reason for it, but they don't seem to be gaining as much weight. And then as I showed in that initial slide on the complexity of the environment, what is their caloric intake, what is their dietary composition, what is their physical activity, what is their conception of what health looks like. So now we're going to move on for our last section, the metabolic consequences of weight gain. And so I think, one of the things that catches our eye, and I think hopefully caught your eye at the beginning, was just the number of people who went from being a normal BMI to overweight and from overweight to obese. And the reason why we have the categories of normal BMI, overweight and obese, and then morbidly obese, is because they do correspond to risk for various metabolic diseases, cardiovascular diseases, and others. So this is just data, again, from NNRTI, and I just want to take a 10,000-foot view and basically just show you here that there are differences among the NNRTIs, the PIs, and the integrase inhibitors in the number of people that jump between categories. 25% of those starting NNRTIs jump from a normal BMI to an overweight, which if you're more of a pictorial fan, you can see right here. And then among the PIs, you can see the number that jump from normal weight to overweight. And then really the greatest jump, though, is 32% of those with a normal BMI jump to overweight at 3 years. And then we can see similar patterns for overweight to obese, 22% for NNRTI, 28% for the INSTIs. In a NAMCEL study, going back across the water, so getting out of North America, this is looking at treatment-emergent overweight and obesity for dolutegravir versus efavirenz. So they looked at this group. Doesn't look like treatment-emergent overweight really differed between the group, but treatment-emergent obesity certainly did. And it should be pointed out that many of the NAMCEL participants were a bit thinner than many of our NA Accord participants. So here we're seeing a 12% emergence of obesity at 96 weeks on the TTG group versus only 5% on the efavirenz group. Okay, staying in Sub-Saharan Africa, going down to South Africa. This is treatment-emergent metabolic syndrome, so obesity, not talking about that now. This is actually people who have got metabolic changes, the development of metabolic syndrome, defined by glucose intolerance, lipid features, and et cetera. So you can see here among those who are on the DTG and the TAF, the highest rates of metabolic syndrome among all participants, dropping off then for DTG in a stepwise manner when you take away the TAF, and then lastly Efavirenz plus TDF, but real sex disparities, which is very concerning. Women were much, much more at risk of developing emergent metabolic disease, particularly 1 in 10 of the women who are receiving DTG plus FTC. Let's also remember that metabolic syndrome, particularly in the form of prediabetes, is the greatest risk factor for the development of diabetes. So why is obesity potentially particularly bad among people with HIV compared to HIV-negative controls? So these are older data from the VA Veterans Aging Cohort Study. And essentially the takeaway I want you to see here is I want you to look at the difference between the odds of having diabetes as you go from a body mass index of less than 20 to obesity among those with HIV and those without. So another way to interpret this would say that you've got a 3.3-fold increased risk of having diabetes if you are an obese person compared to someone with a BMI of less than 20, whereas you've got a 5.4-fold increased risk of having diabetes if you have HIV and you're obese as compared to somebody who's got a body mass index of less than 20. Further data from VAX then looks at incident diabetes, and the takeaway I want you to see here, this is diabetes hazard over the period immediately starting after antiretroviral therapy as compared to HIV-negative controls. Among those who are HIV-negative, as they gained weight, and this shows you here at the bottom the number of pounds that are gained. Pounds, or I think that's actually pounds, yeah. Basically, you can see there's about an 8% increase in the risk of developing diabetes for every 10-pound weight gain. That goes up to a 14% increase. So nearly a double increase of incident diabetes depending on, well, as associated with weight gain in the HIV positive versus the HIV negative. Additionally, the higher BMI and central obesity in particular is going to be associated with faster neurocognitive decline, greater fatty liver disease, cardiovascular events, and multimorbidity in people living with HIV. This cardiovascular event being the weakest, and we'll see some more data for that in a second. So if we look at NA Accord then, this was looking at risk of incident diabetes mellitus after ART initiations. And the reason I like this study is because it gives you two things. It gives you the total effect, meaning what is the risk of incident diabetes depending on the drug that people start on, and then it gives you direct effect, which accounts for the effect of weight in those models. And what you can see here is that many of these confidence intervals cross the median, and this probably does need to be repeated in a larger sample size, but basically compared to NNRTIs, there's about a 16% increased risk of diabetes among those starting integrase inhibitors, which then goes down to a 9% increased risk when you actually account for weight gain. This study only accounted for weight gain out to 12 months, so perhaps this might actually fall down even further if we went further out. Interesting thing that I think needs to be unpacked is what's going on here with raltegravir. The total effect is about a 50% increased risk of developing incident diabetes for those starting on raltegravir versus NNRTIs, which only attenuates by about 10 percentage points when we consider weight gain. Oddly enough, dolutegravir seems to be, at least compared to NNRTIs, protective against developing diabetes. One question is, could this also be a temporal effect as well? So this is something that I think we need to keep an eye on. But I think we need to, the takeaway from this particular analysis is that we really need to consider weight gain in the context of emergent metabolic conditions when we look at the individual drugs. We can't just compare everything to NNRTIs. This was a study that was at CROI 2020 as well that I wanted to show, and I mentioned that some of the data for cardiovascular disease and obesity seems to be a bit weak in individuals with HIV, and that's what this study looked at. So it looked at the risk of diabetes and the risk of cardiovascular events after a BMI increase on ART. So let's look here basically at the normal BMI category. And what you can see is for those who have a BMI increase of 1 to 2 points, or a BMI increase of greater than 2 points, you really see the beginnings of an emergence of higher risk of developing diabetes. All of that seems to be consistent against weight groups, so it's really, if you're going to have some weight gain, you probably want to keep it in the less than 1 BMI unit or the 1 to 2 BMI unit. Interestingly, if we look at CVD, really no increased risk of CVD events in these individuals. Now, this is a bit different than some of the other studies, including some VAX data that's come out, but it is consistent with other studies showing that a higher body mass index doesn't seem to be associated with a lot of change in cardiovascular disease markers, potentially because those are being covered up or subsumed by the increased risk that we're seeing in terms of inflammation with HIV itself. So it may simply be that the obesity effect is sort of drowned out. So in the last 6 minutes, I just wanted to go really quickly through this issue of, in order to understand weight gain, you've got to understand weight loss. So I started my career in Zambia back in 2007, working with the President's Emergency Plan for AIDS Relief. And my area that I was working in was nutritional supplementation for people with a very, very low body mass index starting ART. And back in Lusaka, where I was posted in 07, 08, really, we were seeing about 25% mortality and about 25% loss to follow-up among individuals with severe malnutrition starting ART. So the question is then, what is predisposing to that mortality? But what, really more importantly, what's happening to the body before and after ART? So HIV-associated weight loss is not weight loss in the sense that we think about it traditionally as with starvation. Starvation is preferentially a loss of lipid, and it's a loss of fat tissue with the body's attempt to defend lean muscle. Now, HIV wasting, we see both a loss of fat mass and we see a loss of lean mass or muscle as well. Much of that's driven by increased energy expenditure, loss of appetite. There's accelerated catabolism and reduced ability to lay down, catabolism being a breakdown of fat and muscle, and ability to lay down new muscle mass despite even giving people protein supplements. It changes in circulating lipid levels, reduced nutrient absorption, more rapid bowel transit time, so less time to absorb, and inflammation. So people will lose weight, and then they start antiretroviral therapy, and we get this return to health. So what happens in this period? Well, their resting energy requirements plummet from anywhere from 10 to 30%. So if they were eating X number of calories per day, all of a sudden that X number of calories per day is providing 10 to 30% more energy than they needed initially. People will oftentimes eat more because they get improved appetite, and they don't realize it, but they're actually absorbing more of those calories as well. We see on the ART, we sometimes see impaired ability to deposit the fat where we need to, and we'll get to that in just a moment. We see variable changes in the microbiome, sometimes with what we would still consider to be sort of a pathologic change or a predisposition to microbial translocation and also altered nutrient absorption in these people. They may access, as I mentioned, nutrition and smoking cessation. They may get psychiatric comorbidities treated, and then I think we've gone over specific ART regimens. So all of this plays into what does a return to health look like. And as they gain weight, you can then have a response spectrum where you get a perfect physiological response, and you go from here at the time of HIV infection right back to where you started. Or you get a response spectrum with a variety of either ectopic weight gain or overall weight gain. And this is oftentimes accompanied by loss of subcutaneous fat. So that's the lipoatrophy that we mentioned was so prevalent back in the early PI era, and still it is present to a smaller extent. But really it's the deposition of fat in your viscera, which we mentioned was the central obesity, deposition of fat in your liver, deposition of fat around your heart, and then finally, really an emerging area that's fascinating is the deposition of fat in the muscle, the development of sarcopenia and accelerated frailty, which then leads to all of these various comorbid conditions can be traced back in many ways to a inappropriate or unbalanced deposition of fat in a variety of different organs, leading to what we call lipotoxicity or toxicity from lipids, in addition to other changes. So one thing I want to just end with then is I think that when we think about weight gain on ART, it really does differ by anatomic depot, and it's highly variable. So in these data from Advanced, I want you to see just how much of this weight that's gained is fat in these individuals. So particularly among the women who are on the DTG plus TAP, 70% of the weight they gained at 96 weeks was fat. We see something similar when we look at where weight is gained in ACTG studies. So here we see limb fat only increased by 13%, whereas trunk fat increases by 18%. But trunk fat doesn't tell you whether or not it's that the subcutaneous abdominal tissue, not so bad, here increased by 20%, or the more malignant visceral adipose tissue, which increases by 26% on average. But these raw numbers are not what I want you to see. What I want you to see is the sheer variability that can happen in these individuals, particularly, for example, with that. Some individuals gain very little. They return much more to the healthy physiologic state. Others gain a tremendous amount and are predisposed then to fatty liver disease, insulin resistance, and other drawbacks. One question with all of these 96-week studies is, well, does this reverse, and do people go back to normal further out? Unfortunately, this long-term study basically looked at that very question and found out and showed that actually the lean body mass percentage change, which is shown here for people with HIV in blue, did improve a bit on ART, but then actually over time fell, whereas the trunk fat went up initially. That's what we saw in Advance out to 96 weeks, ACTG as well, and unfortunately did not come back down, but continued to go up over time. So just to end then, what are the different compartments that we need to think about? So as I mentioned, there's the visceral fat, something you can't see in patients, but can be detected either with DEXA scanning, CT scanning, or just monitoring somebody's waist circumference. This is the fat that's underneath the rectus sheath and unfortunately is involved with a lot of the inflammatory and other metabolic changes. There's the role of the fatty liver disease, which driven in part by HIV effects, also then driven in part by your metabolic dysfunction, but really unfortunately leads to a progression from normal liver to steatosis to steatohepatitis, where you actually begin to get sort of some fibrosis and inflammation in your liver and eventually to cirrhosis. And then lastly, the areas that we can't look at it quite as well, but we really need to think about, particularly when we think about cardiovascular risk and function. There's the deposition of fat into muscle, and then there's the deposition of fat all throughout the heart. All of these are emerging areas, and we're still trying to understand to what extent are they associated with weight gain per se, or are they associated with weight gain in the wrong areas, and how do we figure out who's at risk for this? So just to end, it's 1 o'clock, so I'll go through this quick Venn diagram, which hopefully will generate some discussion. So when we think about who's at risk for weight gain on ART and where do we go next, I think if we think about risk stratification, at the population level, it's women, it's non-whites. For ART naive, it's younger. It's older probably for switchers, people with advanced disease, lower CD4, and those with a normal BMI, all at risk of gaining weight. Things we can't see or that we can't think of at the population level: genetics, diet and exercise, health behaviors, psychiatric and psychologic issues. When we go down and look at the comorbidities and the consequences, there's the things we can see. We can tell if our patients get diabetes based on screening. We can do a FibroScan or other imaging for fatty liver. We can look for cardiovascular disease, and unfortunately, in many people, we do see progressive neurocognitive decline. The things that we can't see, though, we can't see their mobility. We can't see what this is doing to their joints unless oftentimes they bring it up or we use imaging. We don't know what this is doing to their quality of life. We don't know what it's doing to their comfort with their body shape. What about meal skipping and supplements? And then lastly, I'm convinced there's a group of people out there just from my own clinic who become so disappointed with some of this weight gain on their agents that they'll actually stop taking them for a period. Mitigation, what can we do as providers? Well, screening. We should be monitoring everybody for who's gaining 5%, who's gaining 10%, particularly those gaining 10%. Let's look closely at their metabolic function. Annual diabetes screening is critical. Routine fasting lipids are also critical. Coronary angiography in those who have anginal symptoms or otherwise at high risk. Also, if you don't want to go that route, you can also do a CT angiography as well. And then liver elastography for those with concern for NASH or NAFLD. Intervention. Selection of initial ART, potential ART switch. Again, I don't want anyone to leave this meeting thinking that I'm suggesting that's a good idea right now, but down the road, I think we need to see more data. Maintaining lipids and blood pressure at goal, early metformin can reduce progression of diabetes, and then finally risk modification. Long-term weight management, just on the provider, we should be monitoring weight and waist circumference. We need to be monitoring body composition assessments. There are structured programs we can enroll people in, and we really need to address weight and nutrition as part of our routine care. In the patient, there's diet and exercise changes, there's calorie tracking apps, there's Fitbits, there's iWatches, food diaries, and then finally, the patient really should discuss their concerns with weight and what the provider might be able to do for them. To end then, future research. We still do not really understand the effect of a lot of these ART agents on multiple systems regulating weight. So we don't really understand the effect on energy expenditure. What is happening to appetite? What is happening with ectopic lipid deposition and who's at risk? And finally, what's happening with adipose tissue energy storage and what's the role of the HIV viral reservoir in the adipose tissue? We don't know the effects of ART regimen change on body composition. We have a bit of data on switches, but we don't have any imaging work to go with that for the most part. We need to learn more about the genetic determinants of weight gain on ART. I think the CYP2B6 and resistant are just the tip of the iceberg there, and I think the future GWAS study will tell us a lot. And then lastly, we really need to think about the impact of weight gain on patients' quality of life and begin to dive in and explore that through questionnaires and other qualitative research. We need to understand what are the barriers for patients to bring up concerns regarding weight with their providers, and what can we do to try and enable those conversations. Okay, so that brings us to the end. 4 minutes over, unfortunately. So now we're going to redo our post-test question. I won't read it again. I'll let everybody read it, though. We can see where the results are. Looking good. Great, perfect. So that's very nice. Number 4 is correct. It's interesting. The pretreatment obesity, I would, starting off, have thought that would have been a major issue. But really, and even though we're seeing, these transitions from overweight to obesity, we see these transitions from normal weight to overweight. Really, when you break it out into kind of a linear BMI, it does really seem to be those with a BMI, the lower end of the spectrum, that gain the most weight. Okay, let's move on then. So that's the end of our talk. So I've seen a lot of great questions coming through the chat, which I haven't been able to answer. I think the moderators now, though, have listed a number of questions in the notes box over here. So I'll just begin with those, unless Jose or Donna have anything to add about the question session. Okay. So the first question we've got, it's Dina Dillon. I'll just use the first name, Dina. Is it known which part of the body the weight is most likely to be added onto? So it is. I mean, what we're seeing, I think, from the ACTG data and also from advanced, is that much of this is going to be trunk fat that individuals are gaining more so than limb fat. So trunk fat is really kind of a definition that comes from DEXA scanning. Which is the low-dose X-ray scanning. And it basically covers kind of everything from sort of mid-chest down to the area of the pelvis. Most of that weight then obviously being kind of in the central subcutaneous fat and in the visceral fat. And then what I was showing with the ACTG data was that there's a preferential weight gain oftentimes within the visceral fat. So that's the fat that's below the rectus sheath surrounding the internal organs, as opposed to the subcutaneous fat, which is above the rectus sheath, but is what we sort of feel, when we kind of grab the skin fold. That would be subcutaneous fat. So the visceral fat is quite detrimental. It drains, much of it drains directly through the portal vein into the liver. It's one of the features that are most associated with the development of fatty liver disease and all the metabolic changes that come then, and it's highly pro-inflammatory. So it does seem, just to summarize though, that this is primarily, in many of these individuals, a central fat gain, though in comparison with the early lipodystrophy or lipohypertrophy area, there's not the wasting of the subcutaneous abdominal fat. So that's still there in bulk. So let's go to Aaliyah next. What, if anything, can be done to reduce the weight gain? And if the weight gain has already been gained, what recommendations do you have to lose the weight? So there have unfortunately not been enough trials of structured exercise and dietary interventions in individuals with HIV. Some of the best data, I think, came from Dominic Reeves at Washington University, who published a study a short while ago where he looked at basically a structured exercise program for women with HIV, and really found that there's no difference in the weight gain that occurs with these programs. And so I think integrating, until we have more data on adjunct therapies, and then also on the potential role of switching, which, as I've emphasized, is not available right now. It's really going to be very similar to what we see in the general population, so dietary modification and exercise. There was some question years ago from some studies that potentially suggested a cardiorespiratory benefit from aerobic exercise in individuals with HIV, but not weight loss, that maybe this wasn't effective. But I think Dominic's data from WashU does kind of suggest that it's perfectly effective, and that's the route to go right now. Terrence, is there an explanation for the low CD4 baseline has a greater weight gain effect? Honestly, I think it probably has to do with greater, essentially more advanced HIV disease. And so as we see, something that we see that came out of studies from the late 90s was that as viral load goes up, resting energy expenditure goes up. So probably those individuals who have the lower CD4 also have the greatest fat and lean mass wasting, but principally fat wasting. And then they probably also have the greatest premium on their resting energy expenditure, so probably well above 10%. So and they also probably have the greatest appetite suppression. So when they start on antiretroviral therapy, they get a large reduction in inflammation, and then they have other features that essentially mean that their caloric intake goes up with better appetite, and they're way overshooting their intended or their necessary caloric intake. So that's my thinking there. Let's see, Pierre, can you explain what leaky gut is, weight gain and fluid in GI, gut health and GI tract instability and chronic infections? Yeah, so the idea behind leaky gut is basically the idea of microbial translocation. So that can be driven by a number of different factors. Early in HIV infection, there's very, very rapid depletion of the immune system, particularly CD4 T cells within the gut. And that then disrupts a lot of the innate or other kind of less pathogen-specific immune responses in the gut. And while you recover some of those CD4 cells, they never fully repopulate. So that then causes sort of downstream effects on an inability to really create a barrier against the movement of bacteria across the gut, and in particular to the movement of bacterial products that are highly pro-inflammatory across the gut. In more advanced stages, it also leads to a shortening of the villi, which are the little fingers that absorb our food. So what leaky gut really is, it's the movement of toxic bacterial products across the gut wall, which do two things. One, they get carried to the liver, create an inflammatory response. And then two, they're also thought to independently cause hypertrophy of the visceral adipocytes, which then obviously surround the gut. So it essentially makes those adipocytes, possibly for a protective reason, kind of bulk up, which then obviously downstream leads to more fats being delivered to the liver, more NASH, things like that. Let's see, from Harold, is Agrifta effective as a treatment to reduce the effects of central weight gain? It does seem to be, but the issue, and I'm not 100% up on any new data, but I do recall that one of the issues with Agrifta was when you stopped it, unfortunately some of the weight gain returned. So there did seem to be a benefit with Agrifta on visceral fat, but unfortunately it was only sustained while on the medication. And I think what we need to find is something that causes more sustained changes that persist after going off the medication. But it did seem to, yes, hold some benefit, and in particular in that kind of critical metabolic area of the visceral fat. So then, Nora, is weight gain considered in current prescribing practices? I'm not at the NASH. It's mentioned in some of the European guidelines as being a potential side effect of a class of drugs, and I think there's FDA warnings as well as a potential sort of side effect or adverse effect of certain drugs. But it hasn't made it into sort of the personalized medicine sphere where we say, okay, this person meets X, Y, and Z criteria, therefore we should select this drug. And others on the call may know more, and they can put it in the chat. But to my understanding, it's not currently a recommendation to select a certain agent based on weight in any of the major national and international guidelines. Why Biktarvy and less weight gain with TAF containing Genvoya? That's a very good question. The Albuterol is boosted, and so one question is the boosting agent actually retarding weight? I mean, there can be some, particularly for the cobicistat, there can be some nausea and vomiting, and so one question is that really also kind of the manifestation also of an immunosuppressive, or excuse me, an appetite suppressive effect? So one potential question is it's not the Albuterol, it's potentially the boosting agent that could be making the Albuterol come out at a little bit lower level. That's sort of the thought right now, because I haven't heard kind of good explanations to the contrary on why elvitegravir would not be performing like raltegravir, bictegravir, dagitegravir. Let's see. Alexa, how does this weight gain by second generation INSTIs play into therapeutic decision-making in comparison with other long-term side effects? Exactly. Let's consider other long-term side effects of other classes, such as metabolic issues with PI, specifically only commonly used PI and atazanavir. At present, I don't think it really does. I mean, these are broad categories of people who are going to have this rapid weight gain out to, 10% plus. It doesn't fall into my prescribing practices at all. If I work in the VA system, I were to see a 35-year-old African-American woman with a low CD4 count, I would still select what I think is, in my opinion, would be probably an INSTI-based regimen for her. I don't think that there's a lot of guidance right now on how we should do that. I think you're exactly correct. I mean, we don't want to necessarily go back to other agents that could have other adverse effects. And I think the same goes for TAF, which I use quite a bit both on first line and also switches. I mean, I think we have the bone and renal data that it's probably safer. And so I think that we need to know that we're not just potentially trading, think we're getting one benefit, but really we're potentially creating another problem. This is all going to, I think, depend on results from switch studies and then really drilling down onto particularly genetics of the people who are most at risk. I mean, weight gain is not benign, particularly when accompanied by metabolic problems, but we need to know who those people are. I think right now you start the best regimen you think for the HIV disease, and then you monitor the weight, you monitor the hemoglobin A1C. Yes, this is good. Since TAF is now being used for PrEP, is weight gain being studied for versus TDF and HIV-negative people? It is. And in fact, I'm glad you asked me about that because I do think, one thing we want to mention is it does seem like there may be something, at least in terms of integrase inhibitors, that does require the presence of the HIV virus. So I think that, if you look at HPTN 077 at week 48, there was cabotegravir versus placebo. And really there's no difference in the weight gain with the cabotegravir versus the placebo. So what's the difference there? Well, one, it's one drug. But two, there's no HIV. So is there something specific about these integrase inhibitors treating the disease, and are they treating it better or treating it differently that's somehow changing this weight gain because we're not seeing it? TAF may be a different story. So in the Discover trial at week 48, basically TAF FTC and HIV negative, they did see a 1 kg weight gain, whereas TDF FTC did not see any weight gain. So there is some question, the 1 kg. I think the other question, though, is 1 kg is only 2.2 pounds, so is it sustained? I think that, if you're going to put people on PrEP for, a very, very long period of time, TAF is a safe, I think TAF is a safe drug. I'm not allowed to say that. But, I think that you have to question what that 1 kg really means, particularly in light of the OPERA data, where it was a very quick bump and then smoothed out again. So I think we need to know more about TAF and PrEP. I'm sorry, I'm seeing chats in the chats, and then they're showing up in the notes. And I was asked to go off the notes, but I think those questions are ending up in here. Have there been any studies examining ART initiation or switch paired with ongoing nutritional counseling directed at minimizing? No, Michael, that's a great idea. And in fact, I think we should all do that study. I think the best thing is you prevent people from gaining weight rather than trying to change things down the road. So I think that, working nutritional counseling at the time of starting ART and making people cognizant to pay attention to their weight and having providers monitor it and try and be proactive in getting people to change their dietary habits. Very easy to send them home with a dietary recall 3-day log, and they can bring it back. And if it's nothing but carrots and broccoli, you're probably in good shape. If it's all pizza, then you probably want to have a conversation with the patient. And then I think, preventing the weight gain early on is going to be a much better thought. And actually, Jessica, I see in the chat here, you did mention that something with TDF keeping weight down. Yes, I think that's actually very interesting. And there is this question: is this TDF somehow behaving like an Efavirenz slow metabolizer? And I don't think we know what the mechanism is, but there is some question as to whether or not, is it really the TDF with weight gain, or is it the TDF preventing weight gain versus TAF actually causing it? Because the abacavir is right there in the middle. So there does, and then AZT obviously is at the bottom in the pooled studies. So there's a spread among these NRTIs that hasn't been well explained. Terrence mentioned, should be looking at bariatric referrals for some patients. Yes, I think so. In fact, we are starting now well, before COVID, we had hoped to really kind of create a pipeline from our HIV clinic to bariatric surgery for evaluation. There was older data, I think primarily with Roux-en-Y bypasses with some concern, if I remember correctly, for PI absorption, but I'm not sure that's really played out. And so far, I think bariatric surgery, while studies are limited, is thought to be relatively safe in these individuals. So here's from Angelina. In the past, I've seen people get switched from atripla to INSTI to modernize their regimen. Do you think, considering weight gain, we should not switch people off atripla if they're otherwise not experiencing any side effects? I think that's tough. I mean, I think that's an individual, provider decision. I think I think you have to look at age, bone density, frailty, neuropsychiatric concerns, if any. Sometimes drill down, make sure that they aren't having potential neuropsychiatric issues that they haven't brought up. I think that's a tough one. Yeah. Again, I wouldn't really make any blanket suggestions in that area. Genotyping people with efavirenz to see if they are going to gain weight is something interesting that is available, that is readily available at a lot of academic institutions. Terrence again, any functional nutrition or exercise studies in longer-term INSTI users? I think I can't recall entirely what the Washington University study was those people were on, but I think it was far enough back that a lot of them were probably on PIs and efavirenz. So I'm not aware of too much in that area for INSTIs. I would recommend though maybe next week Christine Erlinson is going to be talking about frailty, and she might have a little bit more information on that. In someone with wild-type virus who has significant emotional distress with the weight gain and are considering stopping ART, due to this, what do you recommend? Yeah, I mean, that's a hard one. And, we've had a few people who really do take this, some of this weight gain pretty hard. As a provider, I think I can't really make any statements about what I would do. I would never, if they're considering stopping ART, I might have a conversation with them about a switch. Only because it's better for them to be on something, but I think we really want to make clear first and explore what are our other options in terms of activity, exercise, lifestyle changes that they might be able to try and make. And then if we can't make any headway there and it really does look like they're going to stop, I mean, I guess I would consider, but I'm not going to sort of make any recommendations of what I would switch to. I think it would really be probably, more discussing that with them, what's their tolerance for potentially some of the risks with other regimens. Sorry, that probably wasn't the greatest answer. Are you considering some of the newer non-INSTI single-dose options more now with this information? Yeah, certainly. I think so. I think though that I think we'll want to see with some of those agents, we'll want to see a little bit more data, kind of on weight gain, particularly after switch from INSTI regimens. Some of that is probably not happening frequently enough. We're going to be able to really pull it out of the observational databases quite as easily. It's probably something that's going to require a randomized trial. And if somebody, when they do that trial, and I think there actually was a duravirin 3-TC. I can't remember if they had weight involved, and it may have been. I don't remember where I saw that, but I think we need more studies that look at these non-INSTI fixed-dose combinations to see what they do. So I think we're at 1:22, and I'm hearing, oh, sorry, we've gone 10 minutes over. Apologies. I didn't see that. All right, well, thank you all. I can talk about this forever, so. So I think that kind of brings us to an end then. At the end here, we've got our question and answer session, and then I think we're going to switch right to some final slides from the organizers.
Evaluations from today's webinar will be emailed by tomorrow by 5 p.m. Pacific time, and this will enable us enough time to go over those registrants that have pre-registered in advance and those that have attended today's webinar presentation. We have a COVID dialogue series, and tomorrow we will be having an update from the IAS virtual COVID-19 conference and a list of other dialogues to come. To register, please visit our website. And we have a virtual CME update on HIV, and this will be on Thursday, July 30th, and this is directed to the Midwest. However, HIV clinicians in different time zones may also register. And a list of our upcoming webinars are listed. To register, you may visit the IAS-USA website. We also have a 4-part webinar series on pain and addiction. Again, we would like to thank our presenter, Dr. Koethe, for the audience, for your participation, and for the heroic medical community working 24/7 to continue to provide care to people with HIV in the